What you're looking at here is I'm taking an implant removal tool, and it's a reverse threaded conical shaped attachment that binds in the implant as you twist it counterclockwise, and eventually with enough pressure, in many cases you can break the osseointegration bond and unscrew that implant quite cleanly without taking a trephine out and burring away all your bone. And in fact, you can insert another implant directly into the osteotomy if it's in good shape in this manner. So there's the tool inside the broken implant. You can see a portion of the hex has come away, kind of like petals of a tulip. Pieces just come off. And we in fact did re-implant immediately. So back to risk of implant fractures, let's go now to the Straumann at the bottom of the screen. And I mentioned that there's been anecdotal reports that the 3.3 diameter body on the regular neck, which is the internal connection implant, does have a risk tendency. I've actually tried to get some statistics from my company reps, and I can't get any stats. They seem to hold this information close to the chest and just don't want to release that information. So I don't have numbers for you. But let's look back at that slide we looked at before, and let's look at the BioHorizon one piece as our sort of baseline at 648 newtons, and then let's look at the other yellow highlighted one, the 3.3 regular neck ITI or Straumann version, is at 515. So you see it's quite a bit weaker. And if you really look at the catalog, the Straumann company tells you that you should, if you're using this for a fixed restoration, it should be splinted to other larger diameter implants. But a lot of people don't read the catalog that carefully. In fact, I think that you can stretch the envelope a bit. This is my own case where we've got two of these regular neck 3.3 implants in the position of two lateral incisors. And this is a situation where at least we're going to have two splinted together in an area where we can control the forces quite well. And in fact, I don't really believe that there's a significant fracture risk when it's used in this manner, even though it's going a little bit beyond what the company suggests. But here's what you should not do. And I was perhaps negligent in allowing the patient to convince me to do this. We told the patient they needed two implants in the posterior splinted together because I knew we might have to use a narrow diameter. And she had no posterior occlusion. She said, no, I only want one, that's what I can afford, and I should have just said no. But life is not perfect, we're all human. I did do the case with proper patient-informed consent, and my letters to the dentist, it's all documented. Anyways, patient came back about a year after the restoration, and there was some crestal bone loss, but everything was fine, and then I didn't hear from her for 2 years. And then I got a call, so I know right away that's not good. And the implant fractured right off a few millimeters below, sort of where that fixation screw ends is usually the weakest point. And here's what it looked like. And now this is an integrated implant. The abutment screw is broken inside the implant. We can't use our removal tool if we can't get that abutment screw out. This is the worst nightmare in implant dentistry, for sure. This is what you don't want to see. We did trephine it out. It wasn't pretty, and we're going to retreat this case. So even with implants we have today, there is fracture risk. This is another company that has a warning label on their 3.5 millimeter I won't say the surface, titanium implant, it's not alloy, and they tell you do not exceed 45 Newton centimeters of torque when you put this in, or the anti-rotational device at the top of the implant will split open. So we're still dealing with implant fracture risk today. We're not immune to it. Again, if we go back one more time to this comparative strength test, we just looked at the regular neck 3.3 at 515 newtons, which does have a fracture risk, certainly with single posteriors. And when we look at the BioHorizon, we see it's a fair bit stronger. But where is that 3.0 BioHorizon actually indicated for? Well, if we look at the functional loads that we can anticipate with the natural dentition, with incisors it's less than 100 newtons, premolars less than 300, molars less than 700. We know the number for the BioHorizon was 648. If we use a factor of 2, then even 2 times 300 is only 600. So the BioHorizon should be safe even in premolar sites, maybe for some people in the molars. Yet, when you look at the FDA guidelines, it's only officially approved by the FDA for use on maxillary lateral incisors and mandibular central and lateral incisors. It's not even FDA approved for anything beyond that, even though it's probably strong enough to support premolars. based on that last study. So let's look at a few cases now with this particular implant system. And I will tell you that we're going to show you some on-label uses, and I am going to show you some off-label uses where we've used it beyond the specific indications based on the FDA guidelines. So this is a very common situation. Maxillary lateral incisors congenitally missing. The patient's had ortho. I like to do periapicals, and I use these little grid lines that are 1 millimeter apart to help me measure more accurately. We've got at least 6 millimeters intraradicularly, which is good. On the left side, we have maybe a little less, so it's going to be a tight squeeze. We also may have limited bone orofacially that we can't tell without a CAT scan of some sort. And we're going to decide that we will use the BioHorizon 3.0 one-piece implant. That's the intention here. So that's the pre-treatment clinical view of the upper right lateral. Forgive me, I'm using Canadian or international tooth numbering systems. 1.2 means the upper right lateral. There's the upper left lateral. Again, we routinely use implant placement guides when we're using the one-piece implants. As I mentioned before, you've got to get very close to that bullseye positioning, because if you're way off, you can't prepare that abutment too extensively or it's not restorable. So we want to be extra careful. The BioHorizons 3.0 used to be called the Maximus. They come in 18, 15, and 11 millimeter lengths. Here we have a ratchet attached to the abutment, and you see the intraosseous length on this one is 18. We want to get as much initial stability as possible, yet we want to be very careful, both in our mesiodistal angulation and also apically, not to perforate. If we're perforating, we want to shorten up that implant. So we take drill interim radiographs of the pilot drills to make sure we don't have to adjust our angle. We keep our finger on the labial aspect to make sure we're not going to perforate. Ideally, we want to have a CAT scan for these cases as well. We don't always have them in the real world of private practice. And people say, and Carl Misch is known for this, once an implant's integrated, you don't need anything beyond 10, 11 millimeters or so, and I agree with that. But the benefit of a longer implant is for initial stability, especially with these one-piece implants where you're being forced to do an immediate restoration. So I'll go longer if I have the bone to do it, if I'm not at risk of perforating, and the longer the better in these immediate restoration cases. Again, it's only for the initial stability. Once that implant's integrated, I know I don't need anything beyond 10 millimeters. So there's the implant placed at first stage on the upper left. It's the same size implant. This is what the surgery looks like upon initial placement on the upper right lateral. And that's what it looks like before we're suturing in terms of soft tissue closure. But note, we have to keep track of this implant alignment, not only mesiodistally and buccolingually relative to the bone, but also relative to the opposing dentition. So we have to take all these factors into account in the positioning. Here's the left side, and again, similarly, taking the opposing occlusion into account. Now, when the immediate fixed temps are made, they must be out of occlusion. Patients have to know no functioning on this for at least 6 weeks, knife and fork diet, chewing in the back, and you have to have a patient you can trust. Immediate restoration is not for every case and not for every patient, and you have to have a backup plan. Here's what it looks like after 1 week with the immediate fixed temporaries were placed the same day the implants were placed. And here's what the case looks like 3 years after the final restoration. Let's have a close-up look on the right side, what I think is a beautiful result aesthetically and functionally with nice papilla fill similar to the READY study. Remember, by having a narrower implant, we're leaving more bone between the implant and the tooth and less chance of crestal bone loss on the adjacent teeth. And we know through Tarnow studies that the predictability of having an intraproximal papilla reform, even if it's been lost during surgical healing, is the height of the bone on the adjacent natural tooth. And if we're in 4 millimeters, we're very predictably going to have the papilla there. And there's the left side again with not only a beautiful aesthetic result, of course a beautiful functional result. Here's what the radiographs look like after 3 years in function, and to me it looks beautiful. The crestal bone loss is wonderful. Everything looks extremely healthy. The left side is very good as well. And I think this is a wonderful case and beautiful implant design for this particular case. Now granted, not all maxillas will let us put in such a long implant without risk of perforating through the labial undercut, and that's why we have different implant designs and shapes and sizes. Let's look at some other cases now. Let's look at a single mandibular incisor And I'll just show you the final radiograph. Even though we have more mesiodistal space, again, very often we're limited with the bone in the orofacial dimension. Not everyone wants to have a bone graft done. And I feel that why? Why do the bone graft if we can have a predictable result like this with a very strong implant? Let's keep it simple for the patient if we can. Sometimes we do have room for a wider diameter implant. This is a 3.52 piece implant, but we don't always have that room. Let's look at another case where we've had two different implants side by side. In 1995, this patient presented with a perioendo lesion on the lower right central incisor. In fact, we placed one of those Stereos turned or machined titanium implants, 3.25 in diameter, a two-piece type implant. And I showed you this earlier. I promised you I'd get back to it. Don't ask me why the restorative dentist splinted it to the adjacent central, but he did. And actually, it was fine for about 12 years. And then after this long period of time, the patient did develop a large endodontic type lesion or an endoperiolesion lesion, probably the root's cracked. And you see there's a gutta perca cone tracing from the draining sinus tract externally pointing towards the apex. We want to get this tooth out as soon as possible, if for no other reason, not only to try to prevent further bone loss, but I have had a couple of cases where there's been a retrograde infection to an implant from an adjacent endodontic lesion. So we want to get that out, but it's not conducive to an immediate implant with all that infection. We did it on a delayed basis. We used the existing prosthesis, converted the lower left central to a cantilever Pontic, but we had a fair bit of bone loss. You can see that from the occlusal view, but it's not in the aesthetic zone. And if we have enough bone to get in a 3.0 without having to do all kinds of bone grafting, I think it makes sense. If it were my mouth, that's the way I would want to do it. So here we have initial placement of the BioHorizons 3.01 piece. There's the radiograph, and there's the temporary just prior to restoration. So this is after 3-4 months, and now the patient's ready and went ahead with their final restoration. And I think it was a simple way to handle the case. Now let's go a little bit beyond what the FDA has in their official recommendations. And again, with proper patient-informed consent, I think there are cases where I feel comfortable going beyond the FDA guidelines. It's not because I'm in Canada, I'm subject to Health and Welfare Canada, but the guidelines are the same in the Great White North. So here's a cuspid, and again, I want to reemphasize, we really want to routinely use the implant placement guides. There's different designs because we need a bullseye, and there at the time of surgery, you see the positioning of the implant relative to the crestal bone level in the cuspid zone. That's what it looks like on the day the implant is placed. And there's what it looks like 3 weeks later. For some reason, the patient didn't have the temp right away. It was in the mandible. He wasn't overly concerned about the aesthetics. There it is with the tampon and lots of plaque that shouldn't be there. There's the 3 months later, good bone levels. That's what it looks like in the final. And again, clinically from the lingual or from the labial to a little too much tissue, but again, it doesn't show aesthetically. Always better to have too much than too little, and a very pleased patient. We're going to show you later a maxillary cuspid and how we have to pay careful attention to the occlusion on a cuspid. So let me address that on the last case I'll show you. Now let's go a little bit beyond the envelope a bit more, and we're going to do two centrals, splinted though. And you see we've lost mesiodistal dimension. We also have to be concerned with some patients who have a large nasopalatine foramen. We sometimes have very little bone to fit in implants, both mesiodistally and orofacially. So she's got her partial. There's the partial denture out. You can see, and she doesn't want to go through ortho. The soft tissue is thick here. We actually don't have a lot of bone. We're limited both mesiodistally and orofacially. So we got in the two BioHorizon implants. There's the temps. That's what it looks like after 1 week. And here's the palatal view on the final restoration 6 months after it was inserted. Here's what it looks like clinically. Now, I know you want to see a retracted view, so I'm not hiding anything. Here's what it looks like with the retracted view 6 months after the final prosthesis. What does it look like 3 or 4 years later? I do have a 4-year follow-up, and I think this is a gorgeous case. And again, let's look at the radiographs. We look at the radiographs on the day the implants were placed. They probably could have been a little further apart. 2 years after the crowns were inserted, and 4 years after the crowns were inserted. Very stable crestal bone levels, and I'd be shocked if this patient ever had any trouble with these implants for the rest of her life. Now let's stretch the envelope even further. We're going to do a 3-unit bridge on 2 implants from the central incisor to the cuspid. Here we are on the, again, you see that grid periapical that I have. Here's what it looks like clinically. Now, I know some of the dentistry you're going to see here is absolutely horrendous, and I want to repeat what I said before. I do not specifically choose my cases just to show you the pretty ones. And this is a very ugly restoration on that bicuspid. But this is real life. Very often patients don't want you to treat the other stuff, they just want you to treat the implants. Now there's a time to say no, such as active periodontal disease, but I'm going to show you this case, and it's not a pretty case. This patient couldn't care less about aesthetics. All he wants is nothing on his palate, and he wants to be able to chew. And he doesn't want to go through bone grafting either. Can we help him and keep it simple? Well, you're going to see how we did this case. So here's the occlusal view. And we have a lot of challenges here besides the ones I already mentioned. Look at that deep overbite. So we need to be aware of all of this as we're positioning our implants, especially one-piece implants where we don't have the luxury of making customized abutments. Here's the implant placement guide. It can be very simple. Now, I didn't do such a great job here. I'm not even sure why I didn't. But you can see that the 2 implants diverge a little bit. And we know this is going to be a challenge. They will have to be prepared to create parallelism because this will be a splinted restoration. Here's what it looks like occlusally. Here's what it looks like with the tampon just a few days after the implants were placed. This is what it looks like 4 months later. Good bone levels, but is the prosthetics possible? Here's what it looks like with the final restoration in place. And here's what it looks like clinically. And you may say, boy, that really looks ugly. And it does with this retracted view. And even with the patient's smile line, you would say it looks ugly. But as I said before, this patient doesn't care about aesthetics. He just wants a functional restoration, and he wants it fixed, and he doesn't want to have palatal coverage. Yes, it's not a perfect case, but I think we did this patient a good service for that particular patient's needs. Now let's look at what I think could be the most interesting case of all. And that is a young lady who had resorption and associated periodontal bone loss on her upper left cuspid tooth. We took this tooth out, and there was too much bone damage. We had to do some minor grafting. We didn't want to do an immediate placement. 6 months after the extraction, we had a CAT scan done. And you see we're limited there to about 4 millimeters of bone width. And some may say, well, we could do ridge splitting, ridge expansion. She didn't want to go through bone grafting. She wanted the most predictable procedure of all, and I felt putting in the 3.0 one-piece implant would be the most predictable. Now, ideally, when you do these CAT scans, it's nice to have a radiographic guide stent with the outline of a radio-opaque tooth. So you not only know where the bone is, but you know where the bone is and the trajectory of the bone relative to where the tooth is going to go. Because you could say you could fit an implant in here, but if it's coming out halfway through the labial surface, it's not going to be restorable, especially if it's a one-piece implant. But in real life, you don't always have everything done perfectly, and this patient had the CAT scan done, but there was no radiographic guide. To be honest, she was a very limited economic means. The radiologist did me a favor, did this at no charge. The patient didn't want to pay to have a radiographic guide made. Yes, you could say, well, you should say no. But I'm just, being honest with you, we do have these compromised situations sometimes. Here's the pre-occlusal view. She does have some ridge collapse. She has a low lip line. She doesn't need that ridge plumped up for aesthetic reasons. We only need enough ridge just to get the implant in. Here's the facial view. Here's what it looks like on the day the implant is placed. And it looks a bit labial, but it doesn't look to be too bad. Should be within the confines of the future tooth, with a little preparation perhaps. You'll also see in a moment when I show you the occluded model, she had a rotated and opposing cuspid that was fairly prominent. So we knew we had to have some angulation to this implant to jump that tooth over the lower cuspid. If we were too palatal, we would have to restore that cuspid in crossbite, which would not be acceptable. So there's the facial view on the day of placement. We were able to hollow out her existing interim acrylic prosthesis, so it fit over the implant quite nicely. She, in fact, didn't require a fixed temporary tooth. Again, this is a young lady who's on a very limited budget. This is what it looked like a week later, and here's what it looks like radiographically 3 months later. The bone looks perfect, so we're in good shape. And then she sort of ran out of money and just decided not to restore the implant. And she came back a year later, even 2 years later, everything looked perfect, but she didn't have a tooth. I actually called upon a friend and a colleague, Dr. Natalie Wong, who's a prosthodontist in Toronto, and she was extremely kind to be willing to restore this case for this patient at lab cost only. And so that was very kind. I want to thank Natalie once again for that. So here's what the case looks like. It's about 2 years after the implant is placed. 2 years look the same as 1 year. There's no pocket depth. It's biologically integrated beautifully. Again, the alignment is a bit of a concern, especially when you look at this angle. I was saying, uh-oh, I know it didn't move since I placed it, but it's more buccal than what I thought it would be. And I was concerned, is this going to be restorable? And this is your worst nightmare. If one of these is not restorable, you've got to take the implant out, and that will not be easy once it's integrated. These are Dr. Wong's slides. So she likes to put on a little bit of light body first to capture the detail, and then she air sprays it to just get a very thin layer, and then she follows up with the heavy body. And then in the lab, they did reduce the abutment, and then they made a reduction guide made out of Duralay or some sort of similar material. I'm not too familiar with the restorative materials, but you get the idea. And then that jig is sent to Natalie. This is what it looks like on the model after the lab did the reduction. If I could just mention, notice that Natalie, Dr. Wong, took the impression without touching the abutment. That is key, because if the abutment's not adjusted, then the lab can use a prefabricated analog. Once you've prepared that, then you must do a direct crown and bridge impression. So this is the technique. You don't touch the abutment. You take the impression with the help of your lab. You figure out if it's restorable. The lab does the adjustment. They make you that reduction coping guide. And the lab went ahead and made the crown. Here is the reduction guide in the mouth prior to the abutment being modified by Dr. Wong. Then she takes a carbide burr that is supplied with these implants, by the way, and she repeats or replicates the reduction that the lab did by virtue of having this guide. And that's what it looks like in the mouth after the reduction is done. And there's the crown in place. Now, here's where I want to touch upon occlusion, because you don't want to have a cuspid guided occlusion on this 3.0 one-piece implant. You're going to create group function or maybe have little or light contact on that cuspid in centric, in lateral, in balancing, no balancing contact. So you do need to be careful with the occlusion. And this is just showing you how in protrusive and various excursions there is no contact on this cuspid, and in left lateral, if there's any contact, it's certainly group function. So there you get to see the occlusal scheme for this, and this is applicable to all implants, especially if they're kind of implants that may be at somewhat higher risk for fracture. There's the palatal view of the final restoration. There's the buccal view of the final restoration. And here you see, again, in the mouth, in centric. And here's the radiograph of the final case showing you excellent results. Last case I'll show you, which is not really the exact same design. It's a 3.01 piece in the bone. It's exactly the same implant, but on the top it's got a ball. So it's meant for overdentures. So let me just quickly show you that one last case. And we've put 2 of these 3.0 BioHorizon overdenture implants in the mandible. And I want to tell you that I think with partial dentures, it's an area that's largely overlooked as an area where implants can help patients. So if you can get in even just one overdenture type implant on each side of a Kennedy class 1 or class 2, then often you can have the patient get rid of those unsightly, clasps on the natural teeth. And I think it's better aesthetically, it's better functionally. The implants help to maintain the bone. So I think we don't think about implants sometimes with our partially edentulous cases. But this is an excellent implant, even if you have reduced ridges in the buccolingual dimension. So it's not a pretty case, but it does the job. We've got a couple on the right side, we've got a couple on the left side, and there's the occlusal view, and there's the radiograph. And you could see we could use very long implants because fortunately we were anterior to the mental foramen. And as long as I knew I wasn't perforating, as I said before, I like to use the very long implants for that good initial stability. So I think that brings us to the end of our presentation. And I'd certainly like to welcome any of you who would like to contact me. You can email me at murray.arlen@u, as in university, toronto.ca. Or you can visit my website, which is just murrayarlen.com. And I thank you for your attention. Once again, I want to thank Dr. Garber for inviting me to give this presentation, and I look forward to sharing more presentations with you in the future. Thank you for watching. Bye-bye.